This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. Copyright 2013, all rights reserved. My name is Shauna Strickland. I'm a respiratory therapist, asthma educator, and Associate Executive Director at the AARC. I welcome you to today's presentation, Pulmonary Function Exposed, Quality in Pulmonary Function Testing. Upon completion of this AARC webcast, participants will be able to explain the need for quality control, describe the standards for testing, list the pulmonary lab certification options, and explain the need for testing outside a lab. I am pleased to welcome Steve Nelson. Steve is a registered respiratory therapist, certified pulmonary function technologist, and Associate Executive Director at the AARC. Steve is a former Diagnostic Specialty Section Practitioner of the Year, and one of his many projects at the AARC is the coordination of the Office Spirometry Program. Neither Steve nor I have conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Steve, welcome to the program.
Thanks, Shauna. Pulmonary function testing is kind of like a symphony. There are a whole lot of people and parts involved in getting everything right. So to reach something that resembles music, or in our case, useful medical information, it requires that everything is properly tuned and calibrated and all the people know their various parts. Not knowing how much rosin, for instance, I need to put on the bow for my cello to sound good is like not knowing where the predicted values I'm using in a spirometry lab are coming from. And believe me, I can make some pretty nasty noise on a cello. In the next hour, we're going to go through a few of the details that are required to produce great results and what's important on the way. As Shauna mentioned, I don't have any conflicts with the with manufacturers, but I am a member of the Medical and Scientific Advisory Council of the COPD Foundation, as well as working for the AARC. In this presentation, we're going to refer to a few of the programs and services that both organizations provide. So why is quality important? Generally, everything comes down to money. We need to be able to find diseases or find those at risk so they can be treated, or they can alter their lifestyle if that's appropriate, and avoid worsening and the need for increased health care. As an example, at a recent AARP meeting, we were doing pulmonary function testing or spirometry, and I encountered a person who had just recently quit. He had results that were just borderline, nothing out of whack, but the reinforcement to him that he didn't have disease in this case provided incentive for him to continue not smoking. We need to be able to manage diseases so that we optimize the amount of health care the patient requires. How do we know that a treatment has actually been effective if we don't know what our start points and end points are in the disease management process? Next is evaluating disability and a person's ability to continue working. With all the cutbacks in every state and federal program, it's more important than ever that we know who should be considered for alterations to work environment. For instance, going from a potentially hazardous work environment to an office environment. This does affect a person's income since they're usually compensated for the amount of risk involved in a job. And finally, we need to avoid unneeded drugs. There are financial risks and adverse event risks avoided with this as well. With modern medication costing anywhere from $200 to $500 or more for a month, it's a big financial impact. This can adversely affect adherence. In addition, some drugs can cause increased risk for infections and a whole litany of other things that get glossed over in those hushed voices and fast talk that you hear at the end of every commercial on TV. No, that wasn't your speakers. That wasn't the program speeding up. That was me. So the first thing we need to go into detail here is on disease detection. National Health and Nutrition Examination Survey has been going on since the 1960s. They combine interviews and physical exams and studies that look at a number of different factors, including lung health. Currently, they test a sample around the U.S. of people, 5,000 people around the U.S. every year in about 15 different centers. It's based on the CDC data from the Centers for Health Statistics. We know that there are about 12 to 14 million people that have been diagnosed with COPD. Extrapolating the data from the NHANES study, it appears that for each person that's been identified with COPD, there's at least one person that hasn't been identified to this point. So we have 12 to 20 million people out there with some sort of COPD or at risk for COPD that we need to be able to find. We're not the worst, actually, as far as disease detection goes. In the UK, for instance, they have 900,000 people that have been diagnosed. And this is an example where socialized medicine in the country you would think provided better healthcare surveillance so that everybody that had any inkling they might have COPD could go and get tested. Unfortunately, they only have found about a fourth of the people that have been identified. So what do we do to solve this disease detection problem? Do we send everybody to a pulmonary function lab? Do we get spiral CTs on everybody for emphysema? Do we run bronchial challenges? Do we have everybody step up and do phenotesting? Well, the AHRQ about 2 years ago said that we need to stop using spirometry to screen for COPD. They're right, of course. We need to use a structured approach, not just spirometry. We need to find those at risk with questionnaires like the Drive for COPD has been using, and then test this smaller number. This can not only reduce costs, but it reduces the number of errors that are made, since not everyone needs to have an expensive test done. Under disease management, there are W.E. Deming of Total Quality Management fame has said you can't fix what you don't measure. And one of my favorites, Lord Kelvin, he of absolute zero temperature fame, in 1883 wrote, "When you can measure what you're speaking about and express it in numbers, you know something about it. But when you cannot measure it, when you cannot express it in numbers, your knowledge is of a meager and unsatisfactory kind." So as RTs move more into the role of disease management, we need the best tools available to help guide our patient's course. We need more than Kelvin's reference to meager and unsatisfactory kind of knowledge. So why don't we just measure everybody to find these missing millions, for example, with COPD? Let's do a little bit of biostats review here first to see what the implications are. It's depending on the definition that you use for COPD, there's about 5 to 8% of the population is estimated to have COPD. And for asthma, it's about 7 to 9% of the population, again, depending on a number of different demographic issues. What that means is we waste a whole lot of resources running around and having everyone blowing into spirometers and spraying albuterol recklessly throughout the atmosphere. Even though it's been a great community project for years during RT Week, it probably isn't the most efficient way to find cases of COPD or asthma. Now, the idea behind the Drive for COPD was to ask screening questions to identify who is at risk, and then only test those people. And we started off with going to NASCAR events where you have a very target-rich environment. You have a lot of people that abuse tobacco and are at high risk for COPD. On the other hand, if we went to the Kansas City Marathon, we probably wouldn't find as many people that were at risk. So this stepwise approach increases the probability that you will be removing healthy people from needless testing. So sensitivity and specificity are shown here on this disease management graphic. For a screening test, you want a test that finds most of the people with the condition, the true positives, and you don't care much if you get some of the people without the disease, the false positives, and include those in the testing. Unfortunately, this usually means you also pick up a lot of false positive cases. And a simple low-risk procedure, that's not such a big issue. And spirometry is fairly inexpensive and has very low risk. The paper we wrote as a result of the mobile spirometry unit tests showed that using these screening questions, we can reduce the number of tests done at public events dramatically. We recruited over 5,700 people to take the questionnaires. We found 4,200 that were at risk based on the questionnaires and got peak flow on them. Of those that had peak flow, we had 513 that had low peak flows measured on a pocket spirometer. And following up with spirometry, 179 out of the 5,761 people were actually found to have COPD. That means we had a reduction in the number of the tests that we needed to perform by almost 97%. So we ended up with a sensitivity of 41% and a specificity of 98%. So if we said you didn't have disease on the screening survey, we were right 98% of the time. But we tested a few more people than we needed to who were so-called positives, but the time and cost were minimal doing this test. So why not measure everything? Well, here are two examples where evidence does not support what is fairly common practice. In asthma, the EPR3 says that peak flow is not a reliable method to classify the severity of asthma, but is still widely used. Peak flow is useful in monitoring trends over time and is part of an asthma action plan. Similarly, sputum eosinophils and FeNO are graded as evidence D for asthma diagnosis, but they're still widely used as monitoring tools. COPD is determined by the response to bronchodilators, and people typically are just doing pre and post bronchodilator FEV1 evaluations. But that may not be as likely to show improvement or the effect of the treatment as doing pre and post lung volumes. Therefore, the use of pre and post FEV1 may not be the best thing that we can do, and we should be doing lung volumes instead. In most cases, in a primary care setting, lung volumes are not even available, so they can't do that. So that's why they have to depend on the more simple test. Going on to disability, coal workers were the first group specifically identified by the U.S. government as being at risk for lung disease and disability. And back in the 60s, they started to require spirometry to monitor the health of coal workers. In 1978, the cotton dust standard came along, and it was the first regulation to specify that lung measurements had to be done on devices that met minimum accuracy standards. It also mandated properly trained personnel to do the testing to ensure that they were getting good results. And disability actually is a lot wider than just coal workers and cotton dust. Many state programs have to deal with disabled workers in a broad range of industries, and they want to make sure that their benefits are being paid to those who actually need the benefits. Next is the drug risks. Penicillin is an example that I like to go back to. Penicillin was given to everybody when it first came out, and I can remember going to my doctor's office for whatever reason, and you got 28 little white footballs that you had to take over a week period of time. Well, back in the old days, we lived across the street from where the school buses were parked, and we were playing hide and go seek in the school buses. I happened to jump out the back door, the emergency door of one of the school buses, hit my brother in the head and opened up a nice little cut in the top of his head, and he required a couple stitches. Well, he ended up getting penicillin for that, and every other time we got into the doctor's office, we all got our 28 little white footballs. Unfortunately, that resulted in everything, all the various bacteria becoming resistant to penicillin over the long run. Related to the drug risks and problems that we are using right now, there were two meta-studies, Uplift and Torch, that examined the risks of therapy. Torch looked at the LABAs and ICS, and Uplift looked at the effects of tiotropium on long-term maintenance. Both of them showed that combination and monotherapy was safe, but opponents dug into all the details and have found a slight increase in one of the studies. I'm not going to even discuss that part, but one of the studies. And they said that mortality there was more mortality in one of the studies. So, of course, all the experts ran right out to TV studios and started to espouse the dangers of taking these drugs. Well, it even continues today. Just last week, the Cochrane Review came out with a study on LABAs, formoterol, and ICS in asthma. They looked at regular treatment with formoterol and corticosteroids and tried to evaluate the number of serious adverse events. They reviewed 20 different studies in the meta-analysis that included 10,000 adults and 2,700 children. And their conclusion was, it's not possible to reassure people with asthma there is no risk of increased mortality. Well, the result was they only had one asthma-related adult death in about 13,000 subjects, and yet they're telling people to be wary of the increased risk of mortality based on that one thing. So the bottom line is, if you're not looking at the effectiveness, you're wasting a lot of time and money on these drugs. So getting back to the quality, how bad can the quality actually be? Is there a problem with pulmonary function testing? We can do a review of the recent literature here and find out. In a study in Spain in 2006, they went to 50 different primary care offices in Navarre. They found that 2 of the offices knew which reference equations they were using. 7 of them had calibration syringes, but 96% of those had never done a calibration. Only 2% of the clinics actually did daily calibrations. 22% of the clinics had never used their spirometers. 76% of all the tests that were done were found to be unacceptable, and that resulted in 40% of the people having the wrong diagnosis on their charts. In another study done in the Netherlands in 2009, they looked at 15 offices that were working in conjunction with a university hospital pulmonary function lab. They were averaging about 4 tests a week, and the lab reviewed 1,271 different patient sessions. The most common error was too short an effort. 61% of the tests did not have at least a 6-second effort. It's pretty simple to see. You count 1, 2, 3, 4, 5, 6. You look over, and if they haven't been blowing out that long, you tell them to keep blowing. So only 38.8% of the studies met the ATS, ERS acceptability and repeatability standard. There was good news, though. At least 98% of the tests had 3 efforts or more. So they do understand that you have to get at least 3 efforts. And that was in people that were working with a hospital pulmonary function lab. So the next study was done in Finland, and its aims were to assess the quality of primary care spirometry by visual inspection of flow volume expiratory curves and to study the quantity of clinical information provided on spirometry report sheets. So they were not so much interested in what the values were, but they just wanted to see if they could get pretty pictures. They took 868 sessions from 3 different clinics in Finland, and 86% of those, 82% of those that were included had a diagnosis of asthma. So 78% of the tests that they ran were found to be acceptable for the 5 quality tests. Now, again, they did not look for repeatability between the tests. They just looked to see that they had something that looked right. So here were the 5 quality measures, the quality tests that they applied. The first one was, did the start of exhalation begin without delay? There's no hesitation. Second, was there a sharp rise? Third, a sharp peak. 4, no coughing. And 5, was there a full expiration? Well, it's a little hard to determine full expiration unless you're comparing multiple studies. Then they came to this odd conclusion. They said omitting quality review and relying only on the values is a mistake. Well, in my opinion, relying only on the pictures and not the values is also as big a mistake. I agree there's a lot that can be determined about the quality just by looking at the curve, but you need to be able to judge the values and repeatability to take you to get you back into the quality area. The next study was done in New Zealand. New Zealand's actually been one of the leaders for a long time in respiratory physiology measurements. And most of the people working in pulmonary function labs down there have advanced degrees. Quite a few of them are actually PhD researchers. They have a national program that requires people to participate in the quality control sessions, but even there they have found problems. This study looked at the quality of tests following a spirometry workshop. They had 15 offices that were trained and 15 offices that were their control group. The 15 offices that were trained had an initial workshop, and all of the offices, all 30 of the offices, then had a maintenance at standard session that was just held at the 12-week period. And all that was a reminder about what constituted good quality testing. At the end of the study, only 19% of the trained office had obtained at least 3 efforts, and 5% of those in the usual group had 3 efforts. But even more disappointing was that only 13% of the studies in the trained group had good sessions, and these were people who had 2 different periods, 2 different training sessions, and only 13% got good efforts, and 3.4% of those that only had the reminder session had gotten good efforts. Again, test duration was the most common effort that they found during the study. Now, before you get to thinking that it's only foreign countries that have problems, the U.S. also has its own share. This is a study that was published in Respiratory Care in 2005 and looked at pulmonary function practices in the region around Burlington, Vermont. There were 29 practices, primary care practices in the area that were enrolled in the study. 9 of the offices said that they did quality control ranging from daily to annually, and those that said annually meant that they had the technician from the University Pulmonary Function Lab stop about once a year with a calibration syringe. That was their annual calibration. And the offices were offered the opportunity to receive training by a respiratory therapist and a pulmonologist for a free 1-hour session. Prior to the training, 41% of the primary care physicians had no idea what the impact of spirometry was. 38% didn't know how to use their spirometers, and 34% had no training whatsoever on the devices. Following a 1-hour training with the RTs and pulmonologists, they found that 72% of the tests were coming out satisfactory. But physicians still at the end of this period were reluctant to use the spirometers based on unfamiliarity and uncertainty of the interpretation. So we know that training is missing in most cases, and training is important in order to get the best effort and best results out of pulmonary function testing. So what standards are there? What tells us when we're doing a good test, when we're not doing a good test? As I mentioned earlier, there are two different groups that we deal with. There are the National Institute for Occupational Safety and Health and the American Thoracic Society and ATS. The NIOSH was encapsulated in the cotton dust standard in 1978. They said that persons other than licensed physicians should complete NIOSH-approved training. I don't understand why physicians were exempted, since during almost 20 years of doing NIOSH training myself at different courses, the physicians that attended had just as many problems as all the other healthcare practitioners. The standard developed specific standards for personnel doing the testing, and for the training rather, and it said that they must have at least 16 hours of contact. 4 of the hours had to be lecture, 8 hours had to be hands-on, and the remainder could be split between the proficiency testing at the end and whatever else they needed for review. They also said that you had to include training on back extrapolation, hand calculation of back extrapolation on volume time tracings. One of the hardest things these days is to find a spirometer that requires manual calculation of pulmonary function tests. The next most difficult task was to find a device that prints volume time tracings in a size that's actually large enough to measure the back extrapolated volume. So even though it's kind of antiquated and quaint that people still have to learn that for NIOSH, it's in the regulations and they still get taught. NIOSH was also the first standard to designate what was acceptable for accuracy. They said a device had to measure a volume from 0 to 12 liters with an accuracy of 3% of the reading. And several devices at that time were rather proudly boasting that they had accuracy of between plus and minus 5 and 10%. So it was necessary, it obviously was needed to tighten up the accuracy to make sure that we were getting better results. ATS started off back in 1979 with the Snowbird Conference. There were a bunch of guys that got together up at a ski resort, wrote a bunch of ideas down, and came up with the initial standards in 1979. They evidently decided that the skiing was great because they met again in 1986 and published new standards in 1987 and again in 1994. Finally, in 2005, the American Thoracic Society and the European Respiratory Society came out with their current statement, the current joint statement, and they don't specify a credential for personnel, but they oddly recommend that you have to have 2 years of college education. They also say that you should have a refresher course every 3 to 5 years. And they said one of the most important parts of the whole program was to establish a quality control program. They say the quality control program should include regular feedback to technicians on their performance. It should highlight the errors that they've made and include corrective actions as needed to reinforce the need for quality. The equipment standards also included were also included in here. Again, they agreed with the 3% plus or minus 3% accuracy for devices, and they both said that pulmonary function labs should be calibrated using manufacturers' recommendations. Unfortunately, a lot of the manufacturers of simple spirometry devices are now saying it's not necessary to ever calibrate their devices. Part of this is the confusion between calibration and calibration checks or calibration verifications. Most of the small devices used for testing at bedsides and elsewhere cannot be recalibrated in the field, but they can have their calibration verified to make sure that they're still operating correctly. We've done quite a few studies, and we have found some of the devices that, quote, never need calibration actually needed to be sent back because they'd been mishandled or abused and had gotten out of calibration. So you need to verify that the device is still working correctly before you just assume that the numbers you're getting out of it are correct. The most common calibration method is to use a 3-liter syringe on a daily basis and record the results in a log sheet. So when the inspectors come around, you can say, yes, we do our due diligence. And another common method is that most of the devices now print the last calibration date on the actual patient report, so you can monitor that as well. Another method to do calibration that's not quite as accurate is use of biological controls or biological standards. The idea behind this is you do a weekly test on a healthy individual to determine what the long-term stability of your system is. So over a period of 2 weeks, you measure the same person, the same day, same time of day, and calculate what the average value is over that period of time, and add plus and minus 2.5%. Then anytime you notice a change of more than 2.5% in the values, you need to do further checking to see what may be broken. And remember, sometimes it's your healthy person that's broken as well, so don't discount that when you're using biological controls. Finally, reference equations, as I mentioned before, are important. You have to select the right set of reference equations to match the people that you're actually doing the testing on. The ATS-ERS joint statement does not specify any one set of equations, but the ATS has supported NHANES 3 reference equations. These are standard ones that have been developed over the years from the NHANES studies, and again, that started back in the 60s, and they keep updating information. So now they have reference standards for Caucasian, Hispanic Americans, and African Americans included in the equation set. And if your population is going to be markedly different from what the general U.S. population is, you probably need to consider using other reference equation sets. One new option that's just recently come out is from the Global Lung Initiative, the GLI. It was started in 2008 by a group formed at the ERS, and they came up with a complex set of equations that's been developed that covers ages 3 all the way up to 95 and higher. It covers Caucasians, African Americans, Northern Asians, Southern Asians, and they're trying to add the Indian subcontinent, Arabics, Polynesians, and Latin American populations in the near future. And if you do a lot of your own testing and want to get your own normals, if you have 150 normal subjects in a given category, you can plug those values into the GLI equation set, and it'll calculate what the reference equations are for your population. So for instance, if you're in an ethnic area in a large city and you see a lot of one particular ethnic group, you can adjust this to include that ethnic group as well. I spoke with one of the engineers recently at one of the manufacturers, and he commented that using this set of equations was probably the most difficult thing that they'd ever done. So if you're thinking of trying to do this, the NHANES you can actually do with a calculator, but these you need spreadsheets and statistical packages in order to actually implement the equations. But you can expect to see the GLI option on new devices as they come out over the next few years. So those are the standards. Now, what for testing? Now, what do we do about the individual labs themselves? Well, the ATS actually came out with a registry program a number of years ago. It's not a true lab certification, but simply a registry program. You pay $150 for 3 years and then complete a survey that asks about your adherence to standards. And the goal here is to advance the policies of the lab back to the administrators and third-party payers to help show that we are doing quality work. And they throw in a biannual newsletter on top of it. The other organization, WOLFAP, the World Lung Function Accreditation Program, was started in 2000, again at a meeting in Glasgow, by the Association for Respiratory Technology and Physiology. ARTP is the UK somewhat equivalent of the AARC. They don't have the same job descriptions, but they do cover pretty much the same area. So it was a rather ambitious project that covered 4 different areas: training, competence, standards, and quality of the pulmonary function lab. And they realized that there was a large variability around the world, so they started with the Australia-New Zealand model. As I mentioned earlier, they've been doing this quite a long time. But they needed to allow somewhat higher standards in some areas that were specific to country requirements. So they never really got anything gelled. The list of organizations that were included in this certification project are here: the Tasmanians and Australians, the British, the UK, the Dutch, Italians, ERS, and others. Unfortunately, there's still some difficulty in getting this thing launched, so the information was hosted on SpireExpert.com, but it's since been removed pending yet another update. This lab certification actually included more than just completing surveys. It included site visits as well, and the cost of the program was one of the major deterrents to having it go any farther at this point. So part of the quality control programs for each of these different things has been training, and so the easiest way to do it is get good training. NIOSH is kind of the granddaddy of all of them, and it's already been discussed. And if you want to find out where the latest NIOSH training classes are and take one of those, they're 2.5 to 3 days in most cases. Just do a search for NIOSH spirometry courses. The first link that shows up will take you directly to all the listings, and it's easier than trying to remember the long address to get to cdc.nios/whatever. So just search for NIOSH spirometry courses. Spirometry 360 is a little different approach. It came out of the University of Washington, and it's an online training program that goes over the fundamentals of spirometry. It includes a spirometry lab. It goes over performance and interpretation of spirometry, and it has a feedback system. So it's meant to be completed over a several-month period, and during that time you submit all your tests for review during the training and get feedback from experts at the University of Washington about the quality of your tests on a regular basis. There are a number of other providers, such as TechEd Consulting and several others, that will not only do NIOSH training, but have also in the past done customized classes for people as well that have specific needs. And finally, there are the manufacturers and purchasers of complete lab systems commonly get several days worth of training about mechanics and operation of the system, and they get to fly off to an exotic location to get all this training. But most probably people that are buying the smaller devices that actually know nothing about spirometry are the ones that need more training. And unfortunately, spirometry training for handheld devices and screening devices consists of little more than saying, yeah, there's a DVD in the package, just open it up and watch that, and it explains everything. So one of the things that we have to face is the reality that pulmonary function testing is going to be done outside the lab. There isn't any way to get everybody that needs testing into a pulmonary function lab. So where do you find these? You find them in the emergency room, you find them in primary care, clinical trials, occupational medicine, and even in the hospital at the bedside. Anything outside a pulmonary function lab, this isn't quite the controlled environment that the lab has. And what's being tested? In most cases, it's simple spirometry or peak flow. In some cases, it's something like FeNO. So who's doing this testing? Recently, there was a discussion in the diagnostics community on AARC Connect about who is doing it and who should be doing it. Well, some of the members believe that only RTs should be doing spirometry. The fact that a person has a CRT or RRT initial behind their name does not mean they're automatically qualified to do pulmonary function testing. And I'd like to elaborate a little bit. Even though I'm an RRT and just recently took the written exam again, I am in no way competent to work in an ICU. I know all about ME1s and Servo 900C ventilators, but have no idea what ventilators are capable of today. So my competence in the ICU setting is as close to zero as you can get. By the same token, somebody that doesn't perform spirometry regularly would have difficulty doing it correctly. And most people, in fact, only get a cursory trip through the pulmonary function lab as a student. So in addition, there are problems with not actually getting hands-on training with the spirometers. And a point of fact is that there are more spirometers in use in primary care offices than there are total RTs in the U.S. So with that in mind, the AARC has created an office spirometry certificate program to try and improve the quality of tests being done outside the pulmonary function lab. This program is strictly for non-RTs. We're not intending to have RTs take this, but it's intended to improve the quality of the testing being done by people who had no formal training at all in spirometry. As I mentioned, that NIOSH provides the requirements for people doing spirometry in occupational settings, so we're not talking about that either. This is primarily aimed at primary care. The office spirometry certificate consists of 3 different parts. It consists of training verification. We don't do training at the AARC specifically, so we will allow anybody, any of the previous people that we talked about for training, to do the training. They can get NIOSH training, they can go to Spirometry 360 or any place else, or they can even go to a pulmonary function lab and do mentoring in a pulmonary function lab, where they just need to verify they've been trained someplace. We didn't want to develop a whole mechanism for monitoring the effectiveness of the training and adding a whole bunch of different programs to a database and all that, because that becomes too difficult for anybody to manage. So we just said they need training, they need to sign a piece of paper saying that they've had it, and we leave it at that. The next part is a practical test. The practical test covers the different areas of a test matrix that we've determined is necessary. It includes indications for spirometry, that includes patient training, how do you demonstrate to the patient, and how do you find or how do you assess the effort and correct errors that you found. If you want to see the full test matrix, it's available at www.aarc.org/OSC. And then the final part requires that the candidates submit 10 acceptable patient sessions. These are graded for quality. The feedback is then immediately sent to the candidate so that they know how they perform. The certificate then requires annual renewal by submitting an additional 10 tests each year. And this, we think, is a key differentiator. They don't just send us 10 tests and we give them a certificate and off they go. It's only good for 1 year. So they have to demonstrate that they continue to use good quality in their practice, and they have to send the information into us on an annual basis. And the reason that feedback is so important is that it's been shown that excuse me, the quality of testing in the presence of feedback is much better. The lung health study was a multi-center study back in the 1980s that trained a bunch of different people, including respiratory therapists and other healthcare professionals. The initial training was held in these different locations, and people were given spirometers and told to go do testing for this study. The quality soon began to fall off over the first couple of months, and that was during the initial trial, and they were more or less just playing with the devices at that point. But at the end of the third month, a quality feedback system was put in place, so the technicians were getting almost instantaneous feedback on every test they submitted, and they ended up the study at the end of several years with a 93% acceptable rate, so the feedback in that case helped. Likewise, the AARC was involved in a recent project to improve the quality of testing with the office spirometry program and regular feedback. In one particular study we tested, there were 3,740 different patient sessions done, and only 11 of them, or 0.3%, were judged as F quality. This compares to a usual error rate that this company had seen of typically around 3%. So we were 0.3% instead of 3%. So the whole thing here related to quality is pointing out to the fact that we need to try to avoid Lord Kelvin's meager and unsatisfactory knowledge in the pulmonary function lab. Make sure that quality control is not an afterthought. And are there any questions?
Thank you, Steve. That was an excellent, excellent review. Actually, we have a lot of questions, a lot of comments that came through. When we, before we get started, though, you had brought up a point earlier when you were evaluating the different literature that's out there and identified how few people actually did daily calibrations. So I thought I would ask the group, if you're working primarily in a pulmonary function lab, raise your hand if you do daily calibrations in your lab. And then people can continue to raise their hands as we go through this. So I was just curious about that. I found that to be a very odd finding in those studies, and quite frankly a little disturbing. So back to those studies, you had looked at a study with us about the Vermont clinics. Question from the audience, were the Vermont clinics doing government disability testing? Do you have that data?
No, these were just primary care offices that were doing any kind of testing. It wasn't specifically disability testing.
Okay, great. Thank you. We had another user ask you, what are your thoughts on performing spirometry during routine clinic visits for patients with progressive neuromuscular disease process? The question here, the concern was that the patient may not be able to perform well enough to meet the ATS standards or the ATS criteria. So are we really deriving any real value from doing that test?
Maybe. That's a rather difficult question to find an answer to. It may be that there are other tests that are more appropriate than spirometry for evaluating a particular type of neuromuscular disease. So in that case, spirometry would not be indicated. But if something like MIP and MEP, the inspiratory and expiratory pressures might be more appropriate than spirometry in that case, and probably would be the test I'd lean towards.
Thank you, Steve. Another user asked us if you could elaborate a little more on the ATS certification. Do you have that information?
The ATS lab registry program, you can go to thoracic.org, and it's listed. I'll have to look that up and post it, but just go to thoracic.org, and again in their search box look for lab certification, and that pops right up. It's too difficult to put in long URLs anymore, so it's easier just to use Google. Yay!
Thanks, Steve. You also brought up the very sticky wicket of whether it should be a respiratory therapist doing these tests or not, and a question from Kathy in our audience made me think of this. It's my understanding that the person who challenges the CPFT examination does not have to be a respiratory therapist according to NBRC rules and regulations and qualifications for that test. So Kathy asks us, do you think Medicare will enforce the CPFT or RPFT credential for reimbursement someday?
Probably not. The ATS has avoided supporting any one particular credential or set of credentials from any particular organization, and I think that it'll be the same thing, that there will be options as well, but I don't believe that you can take the CPFT anymore, and as you can't challenge that unless you've had the NBRC required training as a respiratory therapist. I can't speak for certain to that, but I'm sure somebody's already looking it up, and you can reply in the chat window if you can verify that. But I think that ended about 4 or 5 years ago.
Thanks for that information. That is good to know, and if anybody does know that, they could type it into the box and inform the rest of it as well. So we have another question about slow vital capacities. If a patient can't perform the forced maneuver of spirometry, would slow vital capacity be reliable enough for baseline?
Yeah, depending again on what you're trying to measure and why you're measuring it. Slow vital capacity certainly is useful for instances like where there's an obstruction or something like that, and people can't fix obstruction or something where they can't blow out forcefully, and they can get more volume out when they're doing a slow volume or slow maneuver than they can in a forced maneuver. Things like where the trachea collapses when they force air out rapidly. We actually did have one of those at the AARP meeting in Las Vegas last week, where a lady had tracheomalacia, and the harder she blew out, the worse her peak flows got. But when she relaxed and blew out slowly, then we were able to get vital capacities, slow vital capacities that were in the normal range for her. So yeah, it is an option for specific indications like that.
And we have enough time for one more question. So this time I'll shift it over to pediatric predicted values. We have a couple of folks who have posted that they've been doing some questionable PFTs on peds because they're, quote unquote coordinated enough as a 5 or 6 year old. Are there specific predicted values to use for pediatrics, or is it on an individual basis? Where do we get good predicteds for that population?
I'd hate to tell anybody to go look at the GLI reference equations because, first of all, they're not included in most of the systems right now. And secondly, you can't just plug in a number and get a result easily, but they do go all the way down to 3 years of age. So that would be one place to look. If you do a lot of pediatric testing, that's probably the only place that you can find references that low. Pulgar, I think, is the other pediatric reference that everybody uses, and I believe that only goes down to 5 years old. But you can do pediatric patients without any trouble. Well, not without any trouble, but with minor trouble. We had a CF clinic when I was working in South Dakota, and we had patients. We had a large number of patients in one area that had CF, and they brought their kids in as early as about 4 years old into the clinic. And at that point, we couldn't really get reliable tests, but by the time they had come in 3 or 4 times, turned 5-ish, somewhere in there, 6 in some cases, they start to understand what the whole process is, and we started to get reproducible results. And most of the kids, by the time they were 5 and 6 years old, but again, it took about a year or more of acclimation to the system for them to be able to perform it properly.
Steve, thank you again for joining us today. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you are watching this program as an archive, this concludes our presentation.